We have just discussed the cranial meninges, the membrane that are mothering the brain, but we haven't seen their clinical counterparts. Now, this discussion is meant to serve for that purpose. What's up, ladies and gentlemen? Welcome back to Neuro Sketch with Dr. Ken. But if this is the first time you've seen this channel, don't forget to subscribe. Today we're going to discuss about the intracranial hemorrhage, bleeding within the cranial cavity, and to be specific, we're going to discuss about epidural hematoma, subdural hematoma, and subarachnoid hemorrhage. Alright folks, let's dive right in. Now, intracranial hemorrhage simply means bleeding within the cranial cavity, period. But bleeding within the cranial cavity can be divided into 4 groups or classes or types if you like. Number 1 is epidural hematoma. Number 2 is subdural hematoma. Number 3 is subarachnoid hemorrhage. And number 4 is bleeding within the brain parenchyma within the cerebrum, and it's called the intracerebral or intraparenchymal hemorrhage. Now, because we haven't discussed anything about the brain, we're going to spare this type for next time, and today we're going to concentrate on these. But you might be wondering, why do we sometimes use hematoma, sometimes hemorrhage? What's the difference? Well, hemorrhage is an active bleeding. You have injury to the vessels, the blood is oozing, is leaking from blood vessels to the spaces. That is hemorrhage. It's an active process, ongoing bleeding. But if you have collection, if you have a localized collection of blood, is referred to hematoma. Now, hematoma is a localized collection of or pool of blood outside the vessels. So yes, hematoma is the result of hemorrhage, but not every hemorrhage will lead to hematoma. Because sometimes hemorrhage does not form this collection, localized collection of blood. And let me take you back here. We have said we have epidural hematoma because it's a localized collection of blood. We have subdural hematoma because it's a localized collection of blood. And then we have subarachnoid hemorrhage because this is not a localized collection of blood. It's like in a process of an ongoing process. The collection has not formed yet, and so it's considered as hemorrhage. Are you ready now to discuss about this bleeding? Yes, let's start with epidural hematoma. Now, epidural hematoma is a localized collection of blood. Hematoma, localized collection of blood. Epidural, in epidural space. Remember, epi means above, dura mater, right? So this collection of blood is above the dura mater, and here it is. Remember, we say the epidural space is a potential space. It's not a natural space. It only becomes a space if you have pathology, and today we have a pathology which is called the epidural hematoma. Now, epidural hematoma is also called extradural hematoma to signify it's outside the dura mater. Extradural hematoma, outside the dura mater. But if you have to be specific, this space between the dura mater and the inner table of the skull. Picture your skull has got 2 tables. It has got an outer table, the outermost one, outer table, and the inner table. Now, if we have connection between the inner table of the skull and the dura mater, is called epidural hematoma. And epidural hematoma is an acute condition but is life-threatening. Listen, this is a neurosurgical emergency. If you suspect your patient has epidural hematoma, he or she should be treated with immediate effect, or otherwise you lose the patient, because this condition is very, very dangerous. So, where is the common location of this epidural hematoma? Epidural hematoma is common in injuries around the parietal temporal region, and if you have a fracture, for example, of the bones around this region, this fracture will result into laceration of the blood vessels, and that blood vessels are oozing, they are leaking blood, and that blood is collecting between the inner table of the skull and the dura mater, and this is considered as epidural hematoma. And you can see the dura mater is being peeled off the skull, and because this blood is forcing in between the spaces. Epidural hematoma is an arterial bleeding. This is worth noting. Epidural hematoma is an arterial bleeding. It's bleeding from artery. And if you want to be specific, you say it's the bleeding from the middle meningeal artery. The middle meningeal artery is the most common artery that is implicated in epidural hematoma. Most of the time, if someone has got epidural hematoma, it would be due to middle meningeal artery. Most of the time, not all the time. And this accounts for greater percent. Now, you remember that the middle meningeal artery is related to these bones here, the parietal temporal region, and remember we have a talion, and we say talion is the weakest point of the skull. So if you receive, and you can see the pterion is related, internal is related to the middle meningeal artery, to the branches of the middle meningeal artery. So if you receive the blow around this region, the blow will result into fracture of these bones, the bones around the pterion here. That fracture will lacerate the branches of the middle meningeal artery. The middle meningeal artery will start bleeding, and that bleeding will result into collection of blood in space, which is called the epidural space. But we have said the injury around parieto-temporal region, but the most common fracture which is involved is the temporal bone. The temporal bone fracture is commonly associated, is the most common fracture that's associated with injury to the middle meningeal artery, and so epidural hematoma. Okay, this is what I was saying. Like, you will receive a blow around this region. That blow results into laceration, fracture of the bones. The bones will lacerate the arteries, the branches of the middle meningeal artery, and they're going to bleed. And because they will start to collect the blood between the inner table of the skull and the dura mater, they're resulting into epidural hematoma. So what are the ages? What are the age groups that are implicated in epidural hematoma? The most common age groups that are affected by epidural hematoma are adolescents and young adults. These are the most common group. Elders are spared in epidural hematoma because, number one, as you are aging, the dura mater becomes really adherent to the bones of the skull in such a way that it's hard for the blood to collect between the dura mater and the inner table. Like, they become really adherent as you are aging. So the blood cannot force itself into the epidural space, and so elders are spared. I've been about 50 years of age, they are spared of by this epidural hematoma. It's not common to them. But why what are the other reasons that account for this high incidence of epidural hematoma in adolescents and young adults? These are the individuals who are associated with high impact injuries. Adolescents like to fight, and remember, if you receive, this is the weakest point of the skull. Okay, even low energy injury can result into fracture of the bones, and that fracture can lacerate the arteries. The artery lacerated result into bleeding result in collection of blood in epidural space. Okay, also young adults also, they are engaging themselves in fighting and all that. No, even boxers, they are engaging themselves in these high impact injuries, and so they have high risk of epidural hematoma. Remember also, they are also involved like in riding motorbike, like they are crazy, border, and they are all exposed into epidural hematoma. Clinical presentation of epidural hematoma varies depending on the severity of the situation, but episodes of loss of consciousness that are intervened with the periods of lucid interval is considered as classic presentation of epidural hematoma, even though sometimes it can happen in other forms of bleeding, but it's considered as classic presentation of epidural hematoma. What does it mean? You have loss of consciousness, and then you regain consciousness, you become clear-minded, you understand everything that was going on, and then you fall another loss of consciousness. So you have two loss of consciousness, and in between you have a lucid interval, and in a period of which you understood everything that was going on before falling another loss of consciousness. And why does it happen? Let me ask you something. What happens when you have sudden impact? What happens? You lose consciousness, right? And then you naturally regain that consciousness after a few seconds, right? Forget about the epidural hematoma. Like, think naturally. Like, what happens if you have sudden impact? You lose consciousness, and then after that you regain consciousness after a few seconds. Now, it happens the same in epidural hematoma. Like, you had a sudden blow, for example, you had a sudden impact, maybe a blow, then you lose consciousness for a few seconds. Now you recover from that loss of consciousness, you regain consciousness, you become full, clear-minded, and then because you have blood is building in this epidural space, is building slowly, and then going to compress the brain, resulting into another episode, the second episode of loss of consciousness. And this second episode is going to be a rapid neurological decline. That is what the lucid interval is, and that's how it is brought about. Like you have 2 episodes of loss of consciousness that are intervened by a period of clear-minded. Lucid interval means, lucid means clear-minded, and then you have another loss of consciousness. And why does the second loss of consciousness happen? Because you have building of blood in this space, and this blood is going to compress the brain. And we've said the epidural hematoma is a neurosurgical emergency. And why is it a neurosurgical emergency? Because of this second loss of consciousness. Okay, because you have rapid neurological decline. The brain is going to be compressed. You're going to have herniation of brain if you are not acting immediately. If you're not acting immediately, and that is a classic presentation of epidural hematoma. Now, it is a neurosurgical emergency, as I've told you, and if not prevented, if not intervened, it can result into herniation of the brain. Remember, the brain had got, the cranial cavity had got several compartments that we discussed when doing the dura mater, right? So those compartments, the brain can shift from one compartment into another, and that's considered as herniation, and herniation can result into death if not intervened, and this is why the epidural hematoma is a neurosurgical emergency. Now, if you do CT scan, this is what you will see. Like you have collection of blood here, and this collection of blood forms a special shape, which is biconvex shape, but because it got the shape of a lens, it's also called a lentiform hematoma. This is lentiform hematoma as is seen from CT scan. Why do we have this lentiform hematoma? Remember, this blood is collecting between the dura mater and the skull. Now, the dura mater is attached to the skull, but the skull has got sutures, and at the sutures is where you have like tight attachment between the dura mater and the skull at the sutures. So this blood cannot cross sutures. It's limited by sutures. It's restricted by suture. It does not cross sutures. And so because we have suture here and suture here, this blood is limited here and here, so it expands at the body here, and so we have this biconvex appearance on CT scan, biconvex appearance on CT scan. So this one should be is a neurosurgical emergency and should be treated immediately. But someone is asking himself, why is it called hematoma and it's bleeding from artery? Yes, it's a bleeding from artery and it's hematoma because initially the blood is oozing, like we have hemorrhage initially. But once you have restriction by sutures, this correction is compressing the blood. It's compressing the blood vessels, and so we do not have no further expansion, but it's neurosurgical emergency. Next, let's discuss about the subdural hematoma, and the word subdural means below the dura mater, and we have a space here. This space is between the internal meningeal layer of the dura mater and the arachnoid mater, and this space is called the subdural space. Remember, the subdural space is a potential space. It's not a natural space. It only becomes a space if you have pathology, and today we have a pathology which is called the subdural hematoma, which is a collection of blood within the subdural space. Now, the subdural hematoma typically become clinically evident in the first 48 hours of injury. What is the main mechanism of injury in subdural hematoma is acceleration deceleration injury. What does it mean? When you have sudden speed up of the head or sudden slow down of the head, result into movement, into back and forth movement of the brain within the cranial cavity. See, forward and back movement. So what? This movement is going to tear the bridging veins. Remember, we said we have bridging veins that are coming all the way from the brain to drain to the jurovenous sinuses. Now, simply, the bridging veins below the arachnoid mater, the bridging veins are soft and flexible because the brain in this space is soft. But above, in subarachnoid, in subdural space and the dura mater, these bridging veins are hard and rigid. Why? Because the dura is rigid and these veins are attached to the dura mater. Now, if you have that sudden shaking of the brain, you're resulting into tearing because the upside here is rigid, not flexible. So you have tearing of these vessels, and so resulting into bleeding within this space, which is called the subdural space and subdural hematoma. Now remember, the main mechanism of injury in subdural hematoma is acceleration deceleration injury, which is resulting into tearing of bridging veins. Now the bridging veins are the most implicated vessels in subdural hematoma. Now that you know the mechanism of injury in subdural hematoma, let's now discuss the age groups that are more likely to be affected by subdural hematoma. But before age group, let's make something very clear here. The larger the distance between the dura mater and the brain, the higher the risk of subdural hematoma. Why? Because the bridging veins are going to travel a longer distance, and so they are very prone into injury. And this distance between the brain and the dura mater is highest in these two populations: the very young population and the very old population. The very young population and the very old population. Why very young? Because in pediatrics the brain is growing, and so the size of the cranial cavity is bigger than the size of the brain, and so we have a higher distance between the dura mater and the brain. Same applies to the geriatric population, the adult population, the old population, because they are aging. The aging in the brain is atrophying, and so we're increasing distance between the brain and the dura mater, and so we have highest risk of subdural hematoma. On top of that, in pediatric population, the bridging veins, they are thin-walled. Their walls are very thin, and so they are prone to injury. Now, let's make it very clear. We have seen in epidural hematoma that the most common groups which are affected are adolescents and young adults. But in subdural hematoma, the most affected groups are extreme of age, the very young population and the very old population. Why? Because of highest distance between the brain and the dura mater, and so the bridging veins are traveling at the great distance, and so they are very prone to injury. Now, in children, this subdural hematoma, this acceleration deceleration can be intentional or accidental. Can be accidental or intentional. And if it's intentional, it is called the shaken baby syndrome. Like, when you violently shake your baby, result into this acceleration deceleration, you see the brain is going to move within the cranial cavity in back and forth direction, resulting into bridging, tearing of these bridging vessels, bridging veins, and resulting into subdural hematoma. And so it is associated with child abuse. And when you are examining this patient with these children, what you see is retinal hemorrhage. Retinal hemorrhage is a classic sign of subdural hematoma in pediatric population, and this thing is associated with the child abuse, the violent shaking of the baby, which is called the shaken baby syndrome. Okay. What are you going to see when you're doing imaging? In CT scan, what you will see is this crescent shape. So we have a crescent breeding here, which is seen in a CT scan, and this is representing the subdural hematoma, and that's got the shape of the banana, and this is the subdural hematoma. Why do we have this breeding? Because we do not have limitation by the sutures. The epidural hematoma was by concho because we had the limitation of expansion by the sutures. But here, because it's within subdural space, we do not have the sutures within subdural space, and so this bleeding can split all over and has got the shape of the banana, and this is called the crescent shape. Next is side-by-side comparison between the epidural and subdural hematoma. You see the subdural hematoma, the epidural hematoma is between the bony and the dura mater, but it is biconchal. Okay, why biconchal? Because we have limitation of expansion by sutures, but also it is bleeding from arteries. It's arterial bleeding, and what arteries is implicated? Middle meningeal artery. The subdural hematoma, on the other hand, is first of all between the dura mater and the subarachnoid mater, and this is a subdural space. And the most common vessels which are implicated here, they are bridging veins. But what is the shape of this bleeding? The shape of bleeding is a crescent shape or shape of banana. Yeah, that is the subdural hematoma. This occurs in what population, and this occurs in what population? What is the mechanism of injury here? Is blunt injury, which is that into fracture. But fracture is not mandatory thing to be present. But here the mechanism of action is axial action, acceleration, deceleration injury. Next, let's discuss about the subarachnoid hemorrhage as the last part of our discussion. And the subarachnoid hemorrhage is the bleeding within the subarachnoid space. This is the subarachnoid space. The subarachnoid space is a space between the arachnoid mater and the pia mater here. And the subarachnoid space is a natural space. It's a natural space for circulation of the cerebrospinal fluid. Remember, we said you have the cerebrospinal fluid, which is circulating in the subarachnoid space, and it becomes to be absorbed by into the venous sinuses by the way of the arachnoid granulation. So if you have bleeding within the subarachnoid space, is considered the subarachnoid hemorrhage and not hematoma. Why? Because it's not a localized collection. This blood circulates with, it mixes with cerebrospinal fluid, and then it circulates with the cerebrospinal fluid. But what are we most worried of in subarachnoid hemorrhage is formation of blood clots. If you have blood clots, the clots are going to lodge in these arachnoid granulations, and they are making it difficult for the CSF to be absorbed into the venous circulation. So what happens? You have blockage of flow, a blockage of natural flow of the CSF, and this is very, very dangerous, and can result into hydrocephalus. And hydrocephalus is very dangerous, is a life-threatening condition if the sutures are already closed. Remember, we have the baby is born with the sutures, like the bones are separated from one another, but once the bones are closed and you have hydrocephalus, that's a life-threatening condition. It's a neurosurgical emergency as well, and that is subdural. That occurs in subdural subarachnoid hemorrhage if the blood clots are going to lodge into these arachnoid granulations, making it difficult for the CSF to be absorbed back into circulation into the durovenous sinuses. So what are the main etiologies of, what are the main causes of subarachnoid hemorrhage? The subarachnoid hemorrhage can be traumatic or non-traumatic. But for non-traumatic causes, the most etiology is a rupture of aneurysm. Perhaps you don't know what aneurysm is, but this bulging of a vessel, bulging of an artery, is like outpocketing of an artery. We have discussed it separately, and is considered aneurysm. Now, if it ruptures in the brain, it will result in collection of this blood in the subarachnoid space, and it is called a subarachnoid hemorrhage, and that is the most cause of subarachnoid in non-traumatic causes. What is the clinical presentation of subarachnoid hemorrhage? Well, the classic presentation of the subarachnoid hemorrhage is this called the thunderclap headache. Thunderclap headache is considered as classic presentation of the subarachnoid hemorrhage. And most importantly, your client will describe it as the worst headache of my life. If you are solving questions in exam, if you are in exam or doing some quizzes, and you see the question says the worst headache of my life, you definitely go for the subarachnoid hemorrhage. Your client will describe it as the worst headache of my life, and this is the thunderclap headache and the classic presentation of subarachnoid hemorrhage. What we're going to so this is side-by-side comparisons between these kinds of bleedings. We have epidural, subdural, and subarachnoid. What is the nature of bleeding in epidural? Is hematoma. Subdural is hematoma, but subarachnoid is hemorrhage because we have mixed the blood and CSF. It's not a localized collection of blood, but what are the major vessels that are involved in epidural? That's going to be your middle meningeal artery. This is going to be your bridging veins, and in subarachnoid it's going to be the belly aneurysm. What are the typical age groups that are affected? In epidural, young adults and adolescents. In subdural, extreme of ages, very young and very old. Elderly and infants. But subarachnoid can affect any age, but it's typical in middle-aged adults. And then what's the mechanism? In epidural, we have fracture of the bones of the cranial cavity, which results in the laceration of the arteries, and it results into arterial bleeding. But in subdural, we have acceleration, deceleration, which results into tearing of the bridging veins, and so we have bleeding. But in subarachnoid, you have rupture of aneurysm. What's the classic presentation? In epidural, remember your lucid interval. Like you have episodes of loss of consciousness that are intervened by a period of clearly minded, and then in subdural hematoma, you have gradual decline of loss, or gradual onset of loss of consciousness. And in subarachnoid hemorrhage is a thunderclap headache, which is described as the worst headache of my life. That is typical of subdural hemorrhage. And then what is another important thing here? Meningeal signs is usually present in subarachnoid hemorrhage, and the patient presents with what? Prominent neck stiffness and photophobia, like sensitivity to light. What about the classic CT presentation? Is by convex or by lentiform hematoma in epidural, but it's crescent, the shape of banana in subdural, and the basal systems in sulci in subarachnoid. And what is the rate of progression is higher in epidural hematoma, it is slow in subdural because this is the venous bleeding, this is arterial bleeding, and this is sudden onset in subarachnoid because it's rupture of aneurysm rupture. What are we most worried of in these conditions? Major danger in epidural is brain herniation. In subarachnoid is brain compression, but in in subdural in brain compression, but in subarachnoid is hydrocephalus. We've just discussed about it. So this is the highest in neurosurgical emergence. The whole of emergence, this is the highest, and this is emergence, but stabilization often before surgery. You have to stabilize the patient before surgery, and this the subdural hematoma is considered less emergence in all these kinds. Alright folks, this sounds like pretty much it, and if you have liked this video, don't forget to share with your friends. But if you have question, additional comment, put your thoughts in the comment section. I read every comment, and see you ready soon.